What would be really nice is, are there people, if I ask you one or two questions and you put up your hands, and that'll give me a bit of a feel of the group. So do we have anybody from the southwest here? Oh, good. From London? Oxford, Reading? Manchester, Salford? Yeah, and Northumberland? Yeah, okay, so we're pretty covered. How many people here are trainers in CYP Act or supervisors? Okay. How many people are commissioners? How many people manage services? And how many people do the hard work? Okay. That's helpful. What I did this morning, and if it's okay with you, I will do that again, is just go over a bit of an overview of what systemic family practice and training is going to look like and how it fits with services. And then I imagine that probably the most interesting bit is going to be sort of questions and discussions. So it's probably easier if I go ahead and sort of do that first. So it won't be terribly workshoppy to begin with. So, oh, and also to say, I was expecting that if Van Eisler would be with me, who has a special interest in the eating disorders module, but he, at the last minute, couldn't. So I can comment on it to some extent, but may have to refer you if it's anything I can't answer. I think, firstly, to say that, we think of child, we think of family. And sometimes families are the people behind children, they're the resources for children, they support them. And sometimes they're also part of distress and difficulty. But either way, as CAMHS practitioners, we really are interested in the family. So I was really, really pleased, of course, wouldn't I be, that systemic family practice has become part of the second wave, because it seems to me that it's a little more than an intervention for conduct disorder, eating disorders, or depression and self-harm, that it's much more training people up to be able to be inclusive of families in whatever other treatments are being given. So the hope is that the spin-off that was in our minds is much broader than the specialisms. So, of course, what do we mean by family? I mean, you all work in CAMHS. You'll know that we think about families in many, many different ways. And in a way, systemic family practice, it's a kind of shortcut, and it means working with those significant people around children who are involved in their nurturing and care, whatever that family will look like. And it may not even be a biological family, it could be a foster family, or it could even be other sorts of networks. And there are lots of ways in which family need to be considered. First of all, of course, as a crucial resource for helping a child. They're the ones who will be, as we know, day by day, minute by minute. And if we don't utilize what families can do around children, then we're really missing out. We also know that family events of all kinds can predispose children to difficulties and also precipitate problems. And families may also inadvertently maintain a problem. A parent who's very overprotective and an anxious child, making the anxiety go on further. Children with conduct disorder or naughty children who get the attention when they're naughty, but people try and ignore them when they're not because they just want them to keep quiet. We all know that from our own parenting as well as our clients, of course. They're also a really important source of information, and of course the kind of information we get with people depends on the relationship we build up with them. So part of being able to sufficiently engage families is to be able to get the best kind of information. But also families are affected by a child's difficulty. So a young person, if a family's lived with an adolescent with eating disorder for a year, they're probably in a different shape from the one they were a year previously. And surely part of what we really need to think about is damage limitation when we're thinking about working with families, that maybe a sibling won't pitch up a few years later for further help. We may be able to make some intervention there that will help. They're also, of course, the supporter of other interventions. They might well bring a child along for CPT or IPT or whatever else is happening. So we need to keep them involved. So it's an essential part of CAM's work, but I think the truth is, probably not where you come from, this is probably not the case, but if you look at CAMs across England, which is what we're interested in this place, a lot of family work is done by people who have very little training. And that's sad because it's not getting the best out of it. So the whole endeavour is to try and skill up the people who are working with families in CAMs so they do a much better job than they do now. So here we are in the second wave. As I say, the specialist modules are conduct disorder, depression and self-harm, and eating disorder, which were partly chosen for us because that's where the clear evidence base is that we can draw from to do it. A little word about family therapy, systemic family therapy, and systemic family practice. Systemic family practice was the phrase we came upon to describe what people will do when they've done the CYP IAPT training. It will reach the sort of second year of a 4-year psychotherapy training, which is, you know, it's substantial, but there is further to go if people want to train as a family therapist. But it will be a more specialised training. So I think people will come out of it being really skilled to work in a CAMS setting, and it will be interesting to know, you know, how that really does work out. But I think that it will be the family therapists who will be doing the supervision, and probably, you know, there will be particularly complex cases which may be taken on by people who've done a full family therapy training. The SFP curriculum group was chaired by Peter Fonagy, as all the others were too, and its membership was drawn from researchers and practitioners with a particular emphasis on those specialist modules, and there are the names of the people who were on the curriculum group. It was from the beginning supported in different ways by the Association for Family Therapy because that has a remit of really wanting to increase good work with families across all the different domains, but also to ensure that the training could be dovetailed in to the family therapy training if people want to continue. So nobody has to begin at the beginning, they can continue on. So that was a very important bit of their involvement. And there were a number of, I suppose, challenges to us as systemic family therapists in drawing up this curriculum. We had to, in this timescale, provide a really good theoretical foundation, because those of you who know about systemic family therapy will know there's a sort of shift in mindset when you have to think of a number of different perspectives in a family, when you have to think of the whole system, how one set of relationships affect other relationships, and so on. And certainly we were advised from Tom Sexton, who's involved in the functional family therapy, which is a manualized approach, especially useful for adolescent offenders, that it's really, really important to get that robustly in the training before you go on to think about the interventions. We also had to base it on evidence. Now, you know, anybody here as a family therapist will know that we do like to be rather creative and go off on our own thing. So for some of us, it was quite hard to keep ourselves anchored onto actually what we did know worked. But it was a surprisingly good exercise, and I think it's done us all good, let's say. We had to integrate CYP IAPT principles within the training, which of course, although there's a lot of overlap when you come down to it in the principles, there are some which are not quite there, like the ROMs and the PROMs and so on. We had to make sure that at the end of those 2 years, practitioners were going to feel confident to go out, to be within their service, to work with families and feel that they could do a good job. With supervision, yes, of course, but as sort of independent practitioners with a good level of supervision. And we also had to make sure that within all of this, there was an understanding of the ethics, of which I think are a bit different when you're working with more than one person in the room. So you have to think differently about confidentiality and so on, and also to make sure that fully integrated were the ideas that we need to hold about working with difference and power, and making sure that we're not making assumptions about family life that don't fit with the people that we're working with. So it's a tall order in a relatively short course. So people will do the core IAP curriculum, of course, and then the basic module. And then they will either do the conduct disorder and depression and self-harm as 2 specialist modules, or they will do the 1 eating disorder module, which is a double module. And that they will come together to form the course. And there are slightly different entry criteria for the eating disorders that I'll come on to in a minute. So it's thought the majority of people will do the depression, self-harm and conduct disorder.
So it says or in the middle, is it?
Yes, it's and, yes. Yeah. Typo, sorry.
Is it the same module that the CYPI Act people will be doing on depression?
Yes, they'll do depression and self-harm and conduct disorder. Do you mean in the CBT they do? No, yeah, no, it's different. It's a different module. It's a systemic approach to depression and self-harm based on different research. Yeah. So the entry criteria are pretty well the same actually as for the other trainings. You have to have a prior professional qualification, you have to be a CAMS worker, you have to be able to study at a postgraduate level, because these places actually training places cost quite a lot of money, and one doesn't want to waste money by just expecting people to do them who actually might struggle considerably. That's not to say that people may need some support, and that's fine, of course. Some experience of working with families, but I think pretty well everybody working in a CAMS service gets that in one way or another. And obviously the opportunities to carry out the required practice with correct supervision. Some people in services might have done an intermediate family therapy qualification, and it might be that they would still get something, or the service would get something extra from them if they did the specialist modules, because not all training will have focused sufficiently on that and be as up to date and so on. So I think that's something services have to play around with a little bit and decide what to do. But I can't see any value in anyone who's done the intermediate training doing the basic module, because all that will have been covered. And if they've done the core IAP module, they'll get the IAP principles and so on and so forth. Now, there's also, of course, some room in relation to those entry criteria, because let's say, I'm certainly on my own course at the Institute of Psychiatry, we've had people apply who might have been, let's say, a midwife, worked in addiction counselling, with new mothers to start with, then moved a bit into adolescent drug counselling, worked in CAMHS a long time, central part of the team, you know, done quite a lot of study and so on and so forth. And they might actually be somebody who the service would get a lot of value from sending on the training. So I think there's an APEL assessment to be done here, which bears in mind all the things about needing to complete the course.
Can I just make a point about that?
Yeah.
Really busy, we've been very clear message that after saying that we have to have a comment on that.
Yeah, well, they do. That's the default, but I think that there will be decisions that might be made locally, exceptionally.
Right. So it's not definitive if we've got somebody with a really good clinical background who can demonstrate equivalency in terms of being a common health professional and the right type of experience and training with families.
But the important thing is, you know, you do a proper assessment based on those different things. Yeah. It makes sense. It's for the service, after all, in the end.
Is this different, though, from... I'm from a local authority in the CAMHS background, and I started doing some of the parenting work.
Yes.
So, because they're not CAMHS workers, they couldn't do the systemic family therapy in the future.
You have to have some experience of working with families. Again, I think that's local decision. You know, you have to be able to study at a postgraduate level. It has to be useful to your service. And you have to have all those basic things about how you work in a multidisciplinary team, you know, how you talk to psychologists and psychiatrists and nurses and, you know, what are diagnoses and all of these sorts of things that people learn.
They're doing all that, but they're not doing this module. I'm just asking if this module's requirements are different to the others then.
Well, they are different in that it's about working with families, so you have to have had some experience of working with families. There isn't any basic difference. What I'm saying is there has to be room for exceptions. So they are the same criteria, but there has to be room for exceptions. So what will people learn? Obviously the theoretical underpinnings, behavioural, structural, transgeneration, communication work. So it's quite integrative. It pulls from a lot of different theoretical ideas. Obviously, engagement, collaboration, therapeutic relationship, very important part because we all know without that you can't do very much at all. Assessment, formulation of presenting problems, how to work ethically and with difference, how to plan work, and also basic interventions, which, when I say basic, I don't mean like really low level and simple interventions. I mean those common core interventions, helping people with communication, helping people express feelings, helping people to talk to each other, that are so fundamental and part of thinking about families and family life. And the other thing that will be included is a little bit about thinking about ourselves in relation to the work, because I think, you know, all of us who work with families know it's so easy to go into a family and become the eldest child, the youngest child, the frightened child, and get drawn into the sort of family patterns. So I think you have to do a bit of thinking about that too. And also how family work might fit in with other interventions that might be carried out in CAMHS, because the assumption is it won't always be an intervention in its own right. It might well be side by side with other interventions, and so how they work together is important. And also how to use formal and informal feedback. I think we've been really good at informal feedback in systemic work. You know, how's it going? Is there anything else I should ask you? Has this been helpful? Should we be trying something else? What's worked for you in the past, etc. But not so good on the formal. So, and in depression and self-harm, again, assessment, especially the developmental issues around self-harm, engaging with the family, especially you know, in order to create a safety net and a safe space around them. Encourage non-blaming explanations of what's happened, because, you know, we all know if families feel blamed, they're probably less likely to change. We want them to feel a little bit of responsibility, but too much blame is counterproductive. Helping the family understand self-harm as a communication, helping them to be able to discuss emotions, which is quite important in that area, and also to identify patterns in the family in order to decrease the likelihood of self-harm, and to use a lot of other interventions just to help people to understand more, to have less risk, and so on. Conduct disorder, that's again much more about engaging and motivating young people and their families. Often they come, whereas someone with depression or who's self-harmed might be in a crisis, so it's working with that crisis. We're often working much more with chronic situations when it's this sort of presentation, so it's slightly different ways of engaging. Building pro-social, family-based behavioural skills. So, this would connect with the parenting. Some of this would very much direct with some of what gets taught in parenting. To prevent relapse and future difficulties. Identify relational processes that might maintain or precipitate particular episodes of difficulty, formulations, and to use mainly behavioural and structural interventions to help families to manage the situation with their young person in a better way. And obviously safety for other members of the family, other children of the family, is also very important in this too. The module in eating disorder is slightly different, and Yvonne Eisler was very influential in the thinking about this. And it is based on the assumption that really to deal with, more than very early presentation eating disorder, you really do need to be fairly embedded in a proper service that can, look after the medical needs of the young person, can engage in multi-family groups and other particular interventions which need more than one solitary trained person in a service. So in order to be in this double 30 credit module, you have to be embedded in a really a specialist eating disorder service. Now this might not be you're all in one corridor. It could be a virtual service, in which people come from different places to come together to create it. But it needs to have a sort of high level of referral and cases going through, and will also require in the training for members of your team, if you're on the training, other members of your team need to join for part of that training, and that's mainly around the multifamily group training and experience. So in some ways it means a much bigger commitment from the team in order to support somebody on this particular module. We've covered all of that. And it includes work with all eating disorders, even and multifamily groups, running family meals, assessment, formulation, engagement, structuring treatment, safety, and all of those things. Yeah. So in terms of thinking in the end how clients will benefit, because that's the only thing that really matters here, hopefully they'll get greater expertise. People will be better at engaging with them in services, or more people will be better, because I think lots of services have got people who are pretty damn good now, but they'll have more people. There'll be interventions available that will take account of all the family members rather than working perhaps with the young person with the family there. It will be more inclusive. There'll be, hopefully in that work, a greater appreciation of family culture in its widest sense, aspirations and strengths, so much easier to work from what the family are wanting for their young person and what the young person wants. Sometimes they're different and you have to work with that difference. Hopefully an enhanced collaboration with families, better ways of supporting families in making changes, because we all know that, we can sometimes see we need to change. We have a go at changing, but actually what we need is a lot of support to make sure that we can embed that absolutely. And also families having perhaps a better understanding of some of, or that the professionals have a better understanding of some of the external constraints on families, about why they haven't perhaps been able to help their young person in the way that they might. And an appreciation of their wider community and network of professionals. So some more understanding of the systems, the referral systems, the professional systems in which people are. And a greater availability of those family-focused evidence-based interventions, which have a specific applicability. Now, I think, you know, as somebody who's been a family therapist for a long time, I've trained people. I think that what we haven't been so good at is helping people who are able to pull out those interventions which are most likely to work. Now, if you've been around the block a long time, eventually you learn from experience what works and what doesn't work. But I think we need to be much better at getting more economical with what we do and choosing the things that work best. And as I said, AFT has worked to make sure that there will be a pathway into complete a family therapy training if people want to so do. Strong evidence on the high quality of supervision practice. One of the questions that came up this morning was about the kind of cases that people might take on. And I think the assumption is that people are going to take on the kind of case that comes in the clinic, and it's not going to be the simple things, because I think when you're working with families, things can't help but be complex in lots of ways. So good supervision, high-level supervision, is going to be essential. And then I think, you know, some wider reverberations. That's just because it's the 5th of November today. I don't know if anybody's remembered, and we should have some fireworks. Is that I think it's, you know, the whole process has, hopefully it will be fantastic for CAMHS. I hope so. You know, the idea that people across England could be better at meeting with families is just amazing to me. But I think it's had quite a lot of effect on those of us who are involved specifically in the family therapy field. We're just revising our training standards in AFT, and I think that a lot of what we've learned in our thinking about what practitioners need in CAMHS will influence especially the first 2 years of training. So it will become possible to do a much more specialist training in those first 2 years. I think systemic practitioners and therapists are becoming much more familiar and comfortable with ROMs and PROMs, and we talk about them and we'll teach people about them, and I think that's good. The flexibility and adaptation, which I think is a huge strength of family therapy, you know, that we do a lot of adapting to fit particular families and their presentation, which is very different from some of our CBT colleagues who are much more concerned that people, you know, do it in the right way. Now, I think we've been kind of influenced by that, and so that I think we've, you know, moved a bit into a different balance, which is that we're becoming much more thoughtful about doing things in a more manualized, protocol-driven way, which sometimes is absolutely the right way to go. So it's about broadening our practice. And certainly in the whole training thing, we've been very influenced by some of our CBT colleagues and have adapted, for instance, the SAGE supervision tool. We're adapting it to make it applicable to systemic supervision. So that collaboration has been really, really important, and it's good to learn from each other. And in the supervision training, of course, CYP app supervision training, there's a systemic section in there now, and also in the core training, so that it gives the opportunity for some exchange of different ideas from colleagues, which I think can only be beneficial and be welcomed. So that's all I want to say in a great rush. And I thought probably the most useful way of the rest of the time to make it more workshoppy would be for people to ask questions. And I'm not sure I quite understood your question, so if you felt I didn't answer it and you wanted to ask it again, that would be great.
Well, I run a team of family support workers.
Yes, yeah. Is that's in the local authority, not a voluntary organisation commission?
And we're in partnership with our colleagues in CAMS
yes.
in IAP.
Yes.
That's why we're
yes.
today.
Yes.
We're actually doing parenting strategies.
Yes.
Yeah. I want to come here about systemic therapy.
Yes. Yeah.
I have some staff who are already trained in systemic
yes.
therapy.
Yes.
And it's certainly something I'm very interested to use much more extensively.
Yeah.
And I know that I have colleagues with a similar service elsewhere in boroughs who've trained their whole teams.
When
I saw, CAMS, you have to be working with CAMS, I thought,
Yeah, well, I think you have to perhaps demonstrate that you have those sort of skills where you get from working in CAMS. I think these things can always be flexible.
Yes, so CBT, IPT, you embark on a structure of sort of 6, 8, 12 sessions with a sort of general direction. You haven't mentioned that with this program.
Yes, you have there's a specified caseload for the basic module and the specialist modules. So in total, you have to have done, I think in each one of them it's seeing a case through to the end, or 2 cases through to the end, double modules. And you have to do altogether across the whole of it 60 hours of practice minimum.
Okay, but from the family's perspective, they're not embarking on a more structured 6 or 8 or
the only
structure
sessions. Is in relation to the particular presentation, where there will be, it's more likely if you're working with someone with conduct disorder, you do this, this, and this. Okay. So there'll be a content, but not an 8-session thing. No.
And sorry, my other question, of not hogging things, is I know that I'll get questions, say at the Tavistock, where they do the 2-year diploma, and then followed by a 2-year master's. Yes. So the implication here is that the 1-year CYP IAP course will count for the diploma, is that?
It would, yes, they're not everywhere calls it a diploma, but the first 2 years,
the first 2 years
is the diploma.
So they'd be ready to apply for a master's? They
would, yes. They'd have to make sure that they'd had the practice elements were in, and they would have to pass an interview for the course. But yes, that the aim is that they would be ready for that. Because the odds are that it's going to probably take, most of the courses have taken more than a year, I think, for people to complete to date.
Can I ask, from the evidence base, do we know which types of families or which types of presentation, considering conduct disorder, for instance, would be better? Who would be better seen by the parenting trainees, and who would be better seen by the SFP trainees? Or depression, for instance, who would be better to receive individual CBT therapy, and who would be better to receive SFP?
I don't think, to be honest, that we really have the clear evidence to direct people, in that direction. There is no doubt, like with all sorts of therapy, that the better you function, the better you do out of therapy. So that it's not the case that you would see for systemic family practice, the families who are the worst families, because they're likely to do worse. So it's a matter of really identifying some aspects of family functioning in the assessment that would be usefully targeted. And that could be both because there are these maintaining factors. It might be that the family really are all up for helping in an enthusiastic way, so that's great, and you could even do some of your, CBT interventions within a family context, for example. And so it really is in the assessment about seeing whether there's a focus that you could use this work for. It's also a bit preference and fit as well with families, and also, you know, there might be issues where you're a bit concerned about risk, not serious risk maybe, but that you really feel it's better to work with the young person on their own. But work with families can sit side by side with that, so it doesn't actually have to be an either or. And in CAMS, most family therapy is not a long venture. You know, it's a relatively short treatment option.
Hi, I just wanted some clarity on the eating disorder pathway as well. I mean, I suppose I've got to go back tomorrow and talk to our partner agencies about the potential of people accessing the SFP training and what we'll need to put forward in terms of the team. And you spoke something about the multi-family group. Yeah. And so is that a specific training?
It's 4 days training.
Yeah, so it's 4 days training.
Yeah.
So can we actually buy that in?
And I think you have to have, I think, maybe 3, but I think it's 4 members of your team taking part in that. If Yvonne was here, he'd tell you it's 3 or 4, but I think it's 4.
Okay, so we could, because I think some CAMS services don't necessarily have that model already.
No.
But so we could actually buy in the 4 days training, specifically looking at an eating disorder pathway or a clinical team to fit in with sort of specialist partnerships and things, and then they could be trained in that sort of 4-day path, that 4-day module.
Well, I think the thing is that people on this training choose that module, the eating disorders module. Let's say you've got 2 people going on it. They would then, as part of their coming onto it, their people who manage their team would have to allow 4 other people from the team to do that particular 4 days. Okay. They don't do the whole thing, but they do that particular 4 days. And that's because the evidence is quite good that multifamily groups are pretty effective intervention as part of an eating disorders team. And you can't actually do it on your own, so you've got to have your colleagues upskilled as well.
Okay, thank you.
It is more, it's more directly about service development, that module. Yeah. And that's why it is different.
Okay, thanks.
I know it's causing a lot of headaches for people. Any other questions? Comments? It's like we might finish a little bit earlier.
Can I just make a quick comment about difficulties that see potentially within teams between trainees?
Yes.
My background isn't family therapy. I'm a CBT therapist and CBT trainer. Yeah. Our CBT trainees and therapists are currently expected to do around 200 hours of supervised practice during the course. Yeah. That's 140 hours more. Yeah. We're expecting a systemic trainee. Yeah. Get both full-time trainees. Yeah. I think that potentially is going to cause some difficulties within the team. I don't know anything about systemic training at all, so I don't understand the systems. Saying to it, people being aware of that. Yeah. For the other pathways, there are significantly higher expectations in terms of hours.
Yeah, I think, in terms of hours, I think that's true, that there's, a difference. I think on the whole, far more work in the systemic world is live supervised. What people do is talked about in different kinds of ways. So I don't think, they might be disgruntled, but I think that this is based on a training pattern that's pretty well established in the systemic world. And often, you have a session with the family, it can take a lot of talking about, it can take 2 hours, or, there's a lot that's sort of different about meeting with a group of people at once. So I think, when people do, but it's a different training, and yes.
I can see your point though, and I'm glad you've made it.
Yeah, no, I can,
I've gone through the interview process for things like down the CPT part.
Yes,
Sorry about my voice. In January 2015, and was told that I would have the option from Leeds. And immediately, I want to know more than you can do today, but I think that's a very valid point. 200 hours clinical hours are clinical hours if it's a similar qualification. So I'm glad you brought it up. Thank you very much.
But you know, that's out there in the world, that if you do different clinical
I'd just like to understand the rationale now of something
yeah.
that's coming down the same streamline can look so from equity
well, I think they're based, I mean, like IPT and systemic family practice and CBT, they're based very much on the trainings as they were constructed prior to CYP IAPT. You know, they're based on experience before that, and it's, you know, it's caused some difficulties between CBT and parenting, for example, which are being ironed out, you know, by BNPT. But it is different. But I think, you know, it's like apples and oranges. They're different folk, really.